It's midday on a beautiful spring day. You've had your coffee and then you're called code 1 to the main street of the town for a 41-year-old female found unresponsive. There's no identification information on her person. No one on scene knows her. She's breathing, she has a pulse, and this is your ECG. The monitor blares the VT alarm. What's your differential diagnosis? What's your provisional diagnosis? And what's your initial management? Hello there, my name's Ryan and I've created this video as a refresher for Ambulance Victoria, ALS and MICA paramedics in managing patients who have overdosed on tricyclic antidepressants. So starting with what tricyclic antidepressants are. TCAs are a prescribed medication that the chemical structure contains 3 rings and a side chain. They can be prescribed for depression, but they can also be prescribed for other ailments, including but not limited to chronic pain and nocturnal enuresis. Tricyclics are well absorbed orally and have a significant first-pass metabolism in the liver and generally have a long half-life. Tricyclic antidepressant medications have their names end in ene, I-N-E. The examples seen on the bottom of the screen are from AV guidelines with the generic name and the brand name. In the middle of the screen, we see that TCAs can be split into tertiary and secondary TCAs. That shows what neurotransmitters they affect, being serotonin and/or noradrenaline. Overwhelmingly, TCAs are prescribed for depression, and due to their risks and side effects, are typically prescribed for severe depression persistent despite other prescribed antidepressants. Depression is thought to stem from a lack of neurotransmitters, serotonin and noradrenaline. As the slide from osmosis education shows, serotonin regulates mood and norepinephrine boosts alertness. In normal circumstances, an action potential moves down the presynaptic neuron and stimulates the neurotransmitter vesicles to move towards the synaptic cleft and release the neurotransmitters. Serotonin and noradrenaline bind to their respective receptors to innervate the postsynaptic membrane. With decreased available serotonin and noradrenaline, individuals are unable to innervate postsynaptic neurons, meaning decreased mood and decreased alertness. This image shows where TCAs have their effect. Tricyclics in the image are shown as navy blue rectangles, and I've circled them in red to make it easier to see. Tricyclics affect the serotonin and noradrenaline reuptake transporters in the presynaptic membrane. By doing this, it affects the reuptake of serotonin and noradrenaline, meaning more of those neurotransmitters remain in the synapse. This increases its time within the synapse and increases its ability to bind to its respective receptors. This results in increased mood and alertness. We can also see tricyclics bound to the central histamine receptor and muscarinic receptors, causing antihistamine and anticholinergic effects. The pathophysiology of tricyclic overdose is dependent on the milligram per kilo. The pharmacologic profile of tricyclics seen on the table on the left of screen shows the various actions TCAs have. These clinical presentations can be transferred to the table on the right of screen. The table on the right is from the textbook of adult emergency medicine, and it shows the likely effect of a certain number of milligrams per kilos of consumed tricyclic antidepressant. We can see the more milligrams per kilo, the increase in severity and symptoms. We can also see that significant clinical toxicity is likely when we hit more than 10 milligrams per kilo. Some quick investigation into how many tablets can be bought from online Australian pharmacies showed that NDAP, being amitriptyline, can be prescribed in amounts of 50 tablets. I was even able to find online pharmacies selling 25 mg and 50 mg NDAP in 50 tablet amounts. If someone consumed all 50 25 mg tablets at once, that would mean 1,250 mg was consumed. And with the average Australian male and female weighing approximately 90 and 75 kilos respectively, it puts the average Australian in the greater than 10 mg per kilo bracket. What we can also see from this table is that TCA overdose tends to have 3 common areas of concern: the anticholinergic effects, the neurotoxic effects, and the cardiotoxic effects. The The anticholinergic effects stem from excess tricyclic antidepressant binding to the muscarinic receptors, preventing acetylcholine exerting its effect. This leads to anticholinergic response. Patient's central temperature will increase. They will have an increased heart rate, mucosal dryness, and potentially agitation, all of which are relatively mild side effects of tricyclic overdose. The neurotoxic effects stem from the blockage of the reuptake transporters and blockage of postsynaptic receptors. Inhibiting the effect histamine and acetylcholine leads to altered mental status or patient sedation. Centrally, histamine causes alertness, and by blocking central histamine receptors results in decreased alertness. Blocking the reuptake transporters results in more serotonin and noradrenaline within the synapse, resulting in increased postsynaptic activation. This results in raising the resting membrane potential of the neuron, which increases the chance of neuronal excitation. Increasing neuronal excitation can lead to seizure activity. Cardiotoxic effects are where tricyclic overdose gets severe. We've already seen that anticholinergic properties cause tachycardia, but tricyclics also cause vasodilation due to alpha-adrenergic receptor antagonist properties, and due to its sodium channel blocker properties, it affects ventricular contraction, which can be seen on the ECG as a widening of the QRS complex. In this slide, I've attempted to show how TCA toxicity affects cardiac myocyte action potential. On the left, we can see a normal cardiac myocyte action potential with an almost vertical phase zero. Phase zero is when voltage-gated fast sodium channels open, allowing sodium to rush inside the cell for depolarization. We can see the QRS correspond with a narrow complex being approximately 0.1 second of width. On the right, I've attempted to draw how sodium channel blocking slows the phase zero, thus slowing sodium entering the cell. The action potential still occurs, but it is slowed due to the increased time taken for sodium to enter the cell. This results in a widened QRS on an ECG, but as toxicity increases, the time for action potential to occur increases, resulting in arrhythmias and myocardial dysfunction. This is where I've attached the clinical features present within the AV clinical practice guidelines, and it loosely follows what the table indicated earlier, that mild to moderate overdose has anticholinergic effects and some neurotoxic depression, but with increased dosage leads to severe toxicity and the symptoms become more life-threatening, with the final line under severe toxicity showing that tricyclic toxicity can cause aspiration, hypothermia, rhabdomyolysis, and acute pulmonary edema. For the next few sections, I will be discussing generalized poison patient as well as tricyclic overdose patient, and I'll compare what the general emergency management recommendations are and compare to Ambulance Victoria guidelines. Physical examination of any overdose patient should start with the fundamentals. What's seen on the screen now has been taken from Tintinelli's textbook of emergency medicine and from the general management, and specifically from the general management of the poisoned patient. The first sentence reminds emergency providers about initial resuscitation and stabilization before clinical risk assessment. Tintinelli discusses what is useful in managing a poisoned patient, being what substance, the dose, and route. It goes on to say that paramedics can provide useful information about the scene, such as different medication bottles, smells, and other materials around the patient. The table on the right of screen looks at differing examinations that can be conducted in the poisoned patient. It is quite an extensive list, but most of these can be completed by paramedics. Looking into what Ambulance Victoria guides paramedics to do with the overdose patient, it too reminds paramedics to focus on fundamentals being airway and ventilation. It then builds to the substance itself, determining what substance, dosage, route, and time. Relevant investigation in overdose setting is asking the conscious patient what medication they have taken and how much. Is it just one medication or is it a polypharmacy overdose? How many milligrams were consumed? The relevance of what time they were consumed can prevent toxicity altogether or aid clinicians into the likely clinical trajectory. If the overdose happened less than an hour prior to paramedic arrival to scene, getting to hospital sooner may prevent absorption of the medication, preventing clinical toxicity altogether. But if the overdose happened multiple hours ago, there is a chance that paramedics will see worsening symptoms due to the toxicity prior to getting to hospital. What did they consume with the tablets? If it's with alcohol, tricyclics can impact the ability for alcohol to be metabolized, causing more problems to the patient. And remembering that alcohol is also a neurodepressant, patients have increased sedation from medication and alcohol. All of what I've mentioned so far is assuming the patient is conscious and coherent to answer questions. If they are altered conscious or unable to answer questions, look at the patient's surroundings. Are there empty alcohol bottles around? Is it just tricyclic antidepressant bottles? Look at the bottles and determine when they were prescribed. Identifying TCA overdose in the patient who can't answer questions can be difficult, and if there is no medication around to aid the diagnosis, it becomes even harder. Highlighted is what Tintinelli says is needed to make the diagnosis. If we don't have the history of exposure and we can't perform urine drug tests, paramedics have to rely on symptomology and ECG findings. Remember the anticholinergic symptoms. Hot as a hair, meaning fever, red as a beet, meaning flushed skin, dry as a bone, meaning dry mucosa, blind as a bat, meaning dilated pupils, and mad as a hatter, meaning delirium, hallucination, and agitation. The ECG findings will vary based on toxicity, but sinus tachycardia with right axis deviation seen with positive R wave in AVR or widening of the QRS complex are signs of sodium channel blocker toxicity. This slide is looking at poison patient management and some tricyclic antidepressant management. The top half of the screen looks at the poison patient in general. Tintinelli again reminds emergency health providers of the importance of resuscitation before structured assessment. It says to follow normal advanced cardiac life support guidelines with the addition of specific interventions for the poison patient. When looking at cardiac arrhythmias in the poison patient, it informs emergency providers to avoid antiarrhythmic medication and to provide sodium bicarbonate. This is followed well by the risk assessment-based approach to poisoning, showing resuscitation at the top of emergency antidote administration being sodium bicarbonate for cardiac arrhythmias. The lower right of the screen shows Tintinelli's management of the tricyclic overdose patient. The red arrows are specific management or medications that on-road AV paramedics could provide for a patient. The blue arrow is pointing at magnesium sulfate. Within Ambulance Victoria, it is only carried by HEMS paramedics. Normally only administered for asthmatic emergencies, if HEMS paramedics found themselves with a tricyclic overdose in refractory torsades, it could be considered. So how does Ambulance Victoria's clinical guideline compare? Looking at AV's guideline for managing the tricyclic overdose patient, we can see that TCA overdose specific interventions are only indicated in what would be severe TCA overdose, and the interventions mentioned are only at a MICA level. The flowchart has the grey box looking for signs of cardiotoxicity being widening of the QRS, hypotension, and ventricular arrhythmias. It reminds paramedics not to administer amiodarone and to administer sodium bicarbonate and to consider RSI with a target end-tidal CO2 of 20 to 25 milligrams of mercury. While ALS paramedics do not carry sodium bicarbonate and cannot RSI patients, they could be presented with an unconscious patient that could tolerate a supraglottic airway and hyperventilate the patient with a target end-tidal CO2 in mind. The goal of emergency management is to improve cardiac functioning and decrease tricyclic affinity for receptors. While the research for this is incomplete, the best understanding to date is that raising the pH and/or raising the extracellular sodium will aid in cardiac depolarization. Raising the pH by adding bicarbonate will absorb free hydrogen ions, alkalizing arterial pH, which decreases TCA's affinity for sodium channels. Increasing the extracellular sodium means higher gradient for sodium to move from extracellularly to intracellularly for depolarization, improving contractility. Another method for increasing pH is by blowing off carbon dioxide by hyperventilation. Hyperventilation decreases arterial carbon dioxide, thereby increasing relative bicarbonate to absorb free hydrogen ions, which results in raised pH. As before, the raised pH results in TCA's decreased affinity for sodium channels and to improve cardiac output. Paramedics must take care when hyperventilating and providing sodium bicarbonate. We want to raise arterial pH, but we currently do not carry point-of-care devices to assess arterial pH. At the bottom of the slide are management goals. We've discussed pH, sodium, and in essence perfusion, but performing rapid sequence induction has a multifaceted management rationale. It protects the airway from potential of aspiration, it regulates ventilation to aid in regulating pH, and it reduces secondary complications such as hypothermia causing rhabdomyolysis. Some special circumstances where tricyclic overdose is mentioned within AV guidelines include managing a patient presenting in ventricular tachycardia and during a medical cardiac arrest. Managing VT, if tricyclics are suspected, amiodarone should not be administered. We have seen amiodarone as a contraindication a few times now, and the reasoning for this is that amiodarone is a sodium channel blocker itself. So managing a tricyclic overdose, which in essence is a sodium channel blocker overdose with a sodium channel blocker, further compromise cardiac myocyte action potential and eventually result in asystole. And if TCAs are suspected in the medical cardiac arrest, sodium bicarbonate should be administered, as mentioned in Tintinelli's textbook, following normal advanced cardiac life support with the added interventions. Other things that may require management with the tricyclic overdose patient include agitation, seizures, hypotension, and hypothermia. Managing agitation can be difficult, and paramedic safety is paramount. Where sedation is required, ideally midazolam to be administered to aid in combating excess serotonin. Managing seizures is the same as normal seizure management. If patient presents with generalized seizure activity meeting status epilepticus, midazolam is to be administered appropriately. Hypotension from vasodilation can be managed cautiously, following the guideline for inadequate perfusion, remembering there could be myocardial dysfunction. Judicious saline administration, ensuring it does not lead to pulmonary edema and/or adrenaline infusions, can be considered to increase perfusion. Managing hypothermia with strip, spray, fan method is just one part of managing hypothermia. Management may require sedation and reducing intrinsic heat production. As discussed previously, rapid sequence induction not only protects the airway, but decreases internal body temperature to aid in managing secondary effects of hypothermia, including rhabdomyolysis. Scene leadership is a difficult message to convey to everyone because it will be dependent on who you are and where you work. But regardless of skill set and work location, be suspicious of tricyclic antidepressant overdose and recognize it early. For microparamedics, if you have a TCA overdose patient, ensure that you're prepared for patient deterioration and provide appropriate management. For ALS paramedics, early recognition and early escalation of care is important. Do your best to prepare for patient deterioration, which may mean just gaining IV access and utilizing a bag valve mask. For metro paramedics, you may be able to load and go fast in providing care for the patient. Early notification of the hospital will aid in patient care. For rural paramedics, you may need to recognize early and start coordinating with the clinician, local urgent care, and HEMS. But importantly for isolated paramedics, reduce your cognitive load. Notify the clinician early and say where you're heading. Allow them to coordinate behind the scenes while you provide patient care. Following on from scene leadership, making the decision to transport can be complicated. A conscious patient with mild symptoms can easily be transported to the nearest hospital with little to no complication. The patient presenting with more severe toxicity is going to require high-level interventions as soon as possible. Other factors to consider is when the tricyclics were consumed. Assuming they were taken orally, if they were consumed less than an hour ago, getting to the nearest hospital with activated charcoal can reduce the absorption of tricyclic antidepressants and thereby reduce the toxicity. It is unlikely that paramedics will face resistance to transport, particularly in the accidental overdose. The only resistance will be the intentional overdose where someone else has called the ambulance. In this case, recognizing that the patient is a significant risk to themselves, paramedics calling for police for a Section 351 will aid in getting the patient to hospital safely. So back to the case at the start. A 41-year-old female found unresponsive. There's no identification information, unknown allergy, unknown history, unknown medications. She's maintaining airway and breathing. She has a good pulse, and this is your ECG. The difficulty with these jobs cannot be understated, and healthcare professionals understand paramedics work in a difficult situation. We are often presented with patients that don't have much information to provide. This case study from ECG Weekly Workout can highlight this. After today's PowerPoint presentation, it's fair to say this patient has a severe tricyclic antidepressant toxicity. But at the start of the PowerPoint, we didn't know this was a tricyclic overdose. You've walked up to a GCS3 patient not knowing if they're on any medication, and you have a monitor screaming ventricular tachycardia. Hopefully after this presentation you can feel more confident in recognizing this patient and how to aid in management through to hospital. For all overdose patients, remember your fundamentals and try to determine the medication, the amount, what time it was taken, and what it was taken with. Thank you for watching. I'm just going to flick through some of the references for each of the slides. Please feel free to provide feedback, both constructive and positive. I do hope you gained something from this today. Thank you very much for watching.